Good evening. It is my very great pleasure to welcome you to the 5th Annual Pharmacy Business Conference, Your Pharmacy, Your Future. We live in strange and challenging times, and the coronavirus pandemic has impacted on us in all manner of ways. From our personal family lives to the way we conduct business, we have all adapted to new ways of living and working. This is our first virtual conference, and we're pleased that you can join us this evening from the comfort of your own home. Over the last 9 months, community pharmacists have shown great resilience and innovation in dealing with the pandemic. Working all hours and under considerable strain, community pharmacists and their teams have gone above and beyond the call of duty in serving communities around the country. As A&E services and hospitals almost buckled under the pressure of huge demand and GP surgeries shut their doors, the local community pharmacist remained open, serving patients with expert advice. The pandemic visibly demonstrated the value of community pharmacists as the only accessible healthcare professionals on the high street. They proved they really are the bedrock of our communities. The pandemic has changed the environment and landscape for most businesses, and healthcare is no exception. It has accelerated the growth of digital healthcare and online platforms, with distance-selling pharmacies growing their collective patient nominations by 62% since January of this year. Amazon has just started to supply prescription medicines in the US, and they have registered Amazon Pharmacy as a trademark here in the UK. Whether you like it or not, the NHS want pharmacy to change, and the consumers of pharmacy services, our patients, are also choosing to change. Pharmacy can no longer be reliant on procuring and dispensing medicines alone. The supply and sale of medicines must be wrapped up within a service which adds value to the NHS, the taxpayer, and the patient experience. Our conference has been curated to help you understand why these changes are necessary and how you can bring about change to create a sustainable future for your pharmacy business. We have a great lineup of speakers who will share some great insights. I'd like to thank our sponsors for supporting the conference and making today possible. So a big thank you to our partners AAH, Bristol Labs, Glenmark, Pharmacy Complete, and Sigma Pharmaceuticals. To take you through this evening's proceedings, we have one of pharmacy's leading experts. Please welcome Michael Holden.
Thank you, Shelley, for that welcome, and thank you all for attending this, the first of 2 virtual events. I'd also like to thank our speakers, panelists, and our sponsors who, together with the team at Pharmacy Business, have helped make this conference happen. If you're on Twitter, please use the hashtag PBConf20 as shown at the bottom of the screen to promote the content and the debates. Please download the conference brochure from the link in your handouts box as well. Here's what you can be expecting for this evening. To start it off, I'm going to set the scene for this conference session. Then, in the absence of the Minister or NHS England representative, I'm going to lay out some of the key expectations the NHS have of us now and in the future. Please do not read anything into the fact that we have no representation from the NHS. They had planned to participate, but are all understandably totally focused on the COVID task force at this time. This session will be followed by Simon Dukes from Psnc, who will set out the ambitions for the sector, but I'm sure he'll also be clear about the challenges and frustrations he has about where we are and the pace of change. We'll finish with a panel which includes Simon and 3 leading independent pharmacy contractors. This is your opportunity to ask questions, so please post them in the questions box as they occur to you. I'd be grateful if you keep them short and very specific, so that we can try and answer as many as possible later. There have been many impacts on community pharmacy during the pandemic, in fact on all of us. The coronavirus pandemic has changed almost everything we think and do. The biggest impact on pharmacy has been increased operating costs, decreased revenue, particularly from services, and significant chaos management factor. The hassle factor, as one independent told me the other day. The community pharmacist contractual framework arrived in July 2019 with opportunities flagged up, albeit some have been delayed by the pandemic. However, it also came with significant challenges on funding. Those funding challenges are clearly highlighted in this report commissioned by the MPA from EY. The report indicates that around a third of the pharmacy network is currently operating at a deficit, even more in the independent sector. If we stay as we are, the report predicts that we will grow to over 2/3 of the network being in deficit, a totally unsustainable position for pharmacy and for the health and well-being of our communities. And finally, as Shailesh mentioned, Amazon has just launched its full online pharmacy in the US, a potential game changer if the supply of prescription and other medicines if it happens in the UK. However, it's worth pointing out that while existing distance selling pharmacies have grown their market share this year, it still only represents about 3.4% of patient nominations. However, it should not be ignored. Perhaps now we need clicks and mortar pharmacy more than ever. You don't need me to highlight some of the specific challenges that this has created for you, pharmacy contractors. However, these factors are largely not in our sphere of control. What is in our control is how we respond to these and others, such as changing consumer behaviors and more. There are a number of enablers for change which could create a sustainable future. Some of these we'll be exploring on Thursday's session, and I'm sure many aspects will come up during the question panel discussion later today. I would now like to launch our first poll of the evening. This will appear on your screen and will give you about 30 seconds to answer before closing and reviewing. Please indicate how confident you currently feel about the future of community pharmacy. Okay, we're going to wind that one up and then we can have a look at the results of that poll. Can we close the poll, please? And then view the outcomes from the poll. So a widespread coverage across the confidence sphere. But it's great to see that we've got some with high confidence and quite a large majority with moderate confidence. What we'll do is revisit this towards the end of the evening. So now, in the absence of anybody from the NHS, I'm going to lay out a few things which are all in the public domain, and I'm sure many of you know them, but I think it's worth highlighting because this will set the scene for some of the debates later. Here are the main policy and contractual drivers that are setting the landscape for the future of healthcare and of pharmacy in this country. They're all interlinked, even if we aren't seeing that or feeling that too much as yet. There are some clear indications in these documents of what the NHS want to buy from us and expects of us, including further reductions in the cost of supplies of medicine, which will require us to examine our processes and efficiencies from procurement right through to the patient. Improve patient safety and health outcomes through the delivery of consistently high quality services. We're seeing this already through the integration of the new medicine service with structured medication reviews in primary care and the new discharge medicine service coming in 2021. Proactive involvement in the prevention of ill health, such as healthy lifestyle advice or the early detection of conditions such as hypertension, atrial fibrillation, and some cancers. And we now have Healthy Living Pharmacy being embedded as an essential service from the 1st of January. This is not a tick box exercise. It's an ethos, a new way of working. The extension of the community pharmacist consultation service with GP referrals should be welcomed. And for the first time in the eyes of many patients and other healthcare professionals, we should be recognised as the front door of the NHS for common illnesses, and we get paid for it. And finally, the integration of community pharmacy into the provision of primary healthcare by collaborating with other pharmacies and other providers within primary care networks. These are all clear indications of the future of our operation. Let me now share with you a few recent statements from Matt Hancock, Secretary of State. He might have had the chance to say them himself if he'd been here. He wants to drive more money towards pharmacy from within the NHS budget. He wants to do a deal with pharmacies where more NHS services are delivered in pharmacies and we get paid for it. The Secretary of State also thinks that pharmacists can do far more, and we are the front door of the NHS in the community. I'm sure Simon will discuss the challenges of converting these words into action. It's now my great pleasure. It's now my great pleasure to welcome Simon Dukes, the Chief Executive of Psnc, to update us on the latest position within the contractual framework and no doubt share some of those frustrations that he has in relation to that, plus the ambitions of our interactive panel debate. Simon.
Thank you, Michael, and good evening, everyone. I hope you're all well. Thank you for taking the time to attend this important conference. I hope evenings like this give people a chance to pause and to reflect about the bigger picture for their pharmacies, and perhaps to hear some different points of view, but I know how challenging it is, and it must be right at this moment to take any time away from the day job. I'm grateful also to Pharmacy Business for the invitation. My topic, as Michael said, for this evening is Community Pharmacy Ambitions. And at the moment, from what my committee members and other contractors tell me on a daily basis, your main ambition is to get your pharmacies and your teams through this winter unscathed. And I know how difficult that's going to be. And I want to talk a bit tonight about what the Psnc committee and my team are doing to help. Of course, I'll focus on the pandemic, but as news of vaccine progress hits the headlines on a daily basis, I also want to look a bit beyond COVID-19 and share some wider ambitions with you. I also want to address some of Mike Holden's points, as he said, and I know that many of you will have lots of questions about the ongoing negotiations. So I'll start by giving you an update on where we are right now and what we're asking for, and then set out what our bigger picture ambitions for the sector are. As always, I'll be keen to hear your thoughts and your feedback afterwards. There's a panel Q&A, but also you can find my email address on the Psnc website. So since the start of 2020, we have been talking about the very worrying pressure being put on community pharmacy businesses, whatever their size and whatever their location. In February, we wrote to ministers setting out our concerns and calling for urgent discussions on community pharmacy capacity and funding. Of course, COVID-19 then hit our shores, and before those discussions could really take place. And we know that its impact has been to intensify the pressure on pharmacies beyond anything we could have imagined back at the start of this year. There has been a huge amount of work required in dealing with this pandemic, from sourcing PPE and reassuring anxious patients to grappling with test and trace and social distancing measures. All of this making life hard for you and your businesses. As we now know, despite reassurance from government that things would get easier, our concerns about the impact of a second wave of the pandemic were also justified. Now, in some ways, the second wave of COVID-19 in the UK has been easier to manage. We've been here before, and this time patients have been less panicked, and the NHS has had some chance to prepare. Pharmacies already have their social distancing measures in place, and systems for ordering PPE are up and running. But in other ways, this wave has been harder than the first. Government messaging has been no less mixed, and while the ambition of a local tiered approach may have been great in theory, In practice, it has been a muddle, and as a sector, we've not been able to act so collectively. Pharmacies' experiences of NHS test and trace have been at best shambolic and at worst disruptive. I know that for some contractors, the reduction in pharmacy staff caused by inappropriate self-isolation orders has left them in constant crisis mode. Almost 60% of pharmacies in our recent survey told us that members of their staff had needed to self-isolate. More than 40% had to use locums to help, and more than 45% said the disruption lasted between 8 and 14 days. In addition, I should add that 63% of pharmacies tell us they still cannot access tests for their staff easily. And unsurprisingly, more than 3/4 wanted more support from government. At a national level, decision-making remains very slow. We see penny pinching on a grand scale, and officials are simply not doing enough to support the sector on which they and the network of GPs rely on day in, day out. Don't just take my word for it. Let me remind you of parts of the open letter that Jo Churchill, the Parliamentary Under Secretary of State for Health, sent recently to the sector. She talks about community pharmacies having to adapt early to the pandemic to maintain medicine supply, and says that this is a role that is important under normal circumstances, but of vital importance at this moment. She said, "You have remained open throughout the pandemic, innovated in response to the challenges it's brought, and shown immense resilience." She goes on to say, "I know how hard you have worked to support your communities. You have done an incredible job, especially on the medicines delivery service for shielded patients, and you are central to the delivery of this year's expanded flu vaccination program." And she ends by saying, "My ministerial colleagues and I remain hugely grateful for the efforts community pharmacy teams continue to make to support all of us." Jo Churchill's words are welcome, but we are continuing to press government to turn that gratitude into financial support. And from the comments I've had over the last week or so, I know only too well the views of the sector, which mirror those of the Psnc committee on the value of platitudes versus tangible offers in the negotiating room. You will know that negotiations to get more financial support for contractors are ongoing. This has been the case for many months. We are using data to make our case and not accepting anything below our principles. Psnc is taking two modes of attack on money. First, we're pushing for the full costs of the pandemic to contractors to be covered by the Treasury, in line with government promises. And second, we've made a comprehensive bid for an uplift to the annual funding linked to the Community Pharmacy Contractual Framework 5-year deal. We were optimistic about both of them when we submitted them earlier in the autumn, and we still are. But the latest update on these two topics tells us much about what the NHS and Her Majesty's government thinks about our sector, because the update is that there's been no progress on either. We are yet to receive any response to our bid for funding uplift, and I don't believe we will until the current abridged spending review process has run its course, and more details, of course, about wider NHS spending are likely to be revealed tomorrow. And we wait still a response from the Treasury to our most recent proposal on COVID-19 costs. You may have seen pharmacy press coverage recently suggesting that a funding offer had been made and was with Psnc. It's true that an offer was made by the Department of Health, but this was over the summer, and that offer would not have even covered the impact of the pandemic on contractors for 3 months, let alone ongoing costs. It would have constrained the total funding being given to a level which we could not possibly accept. And it would also have required contractors to make historical claims, which they may or may not have been able to evidence. The Psnc committee rejected it. Instead, we proposed that the full £370 million of advance payments given to the sector should be written off against COVID-19 costs for a fixed period, which could then give us time to create some kind of claims-based system. Department of Health officials say ministers are considering this carefully. And this could be good news if it means they are doing so in the context of this being a fair claim for a sector that finds itself at the very heart of a COVID storm. The Department of Health and NHS England must understand that when we say pharmacies are falling over, we mean just that. I know that in many areas, LPCs are working hard to keep pharmacies open short term, and some LPCs have told us that they expect to lose 10% of their local contractors to financial pressures by early next year. I've said it before, but this just seems utterly unthinkable in the middle of a global health crisis. But this has been, I guess, a year of unthinkables. But while it comes to business survival, it's about money. In every other way, it's so much more than that. It's about your patients. We currently have a significant number of other asks sitting with NHS England. We've highlighted to them the many operational pressures on your businesses, and we've asked for a range of measures to help you grapple with them. So many of these things have been in discussion for weeks and even months. As we saw in the first wave of COVID-19, decision-making is simply too slow to be effective. This decision paralysis reflects what we're seeing on the national stage as politicians seek to please everyone and over again struggle to take control of this national crisis. So what have we asked for? Well, to reel off but a few of the things that we think would help you help your patients, as follows. We want more time for you to complete part 2 of the pharmacy quality scheme and any PQS for 2021-22 to be delayed. We've asked for this, but warned that this must not delay delivery of monies to you. We want national announcements allowing you to work behind closed doors when needed and to focus exclusively on vaccinations for parts of the day. The regional announcements on opening hours are helpful, but they're not enough. We want regular testing of community pharmacy staff, and we want national guidance to help tackle NHS test and trace issues. We want the pharmacy audit and the community pharmacy patient questionnaire waived. NHS England has said already its clinical audit will be waived this year, but this needs to be confirmed. And finally, we want contractors to be given the freedom to prioritise patient-facing services, so they do not have to comply with, for example, routine data requests until further notice, and they have clarity on Christmas and New Year pharmacy provision as a matter of urgency. Why the NHS has not been able to agree all of this by now, we simply do not know. But rest assured, my team are fighting hard on all of these points. The unfortunate truth is that although some officials are sympathetic to the pressures that so many of you are under, others require evidence. This is the demand that we come up against time and time again. Whatever we say and whatever we ask for, we need to provide robust evidence for it. And by evidence, officials usually mean data. So this is the reason why we ask you every month for financial data. This is why we continue to badger our committee members for detail and information. And this is why we keep launching surveys and are happy to support others, from the all-party parliamentary pharmacy group to Health Watch organisations when they do likewise. Because time-consuming though this may all be, all of these surveys and all of this data is critical in giving us the evidence we need to make your case. So thank you if you are one of those who have supported us in these endeavours. But as well as grappling with all these challenges, we must allow ourselves to think about the possible light at the end of the tunnel and to keep thinking about our ambitions for the future. And some light did come last week and this in the positive preliminary results of the first COVID-19 vaccinations. This is undoubtedly good news, but again, we must have some perspective. Will this be the thing that gets the country out of the woods? Possibly, eventually. But even the scientists at the head of the race who have an interest in promoting the good that their vaccine will do think we have another year before we can regain any sense of normality. And what will it mean for pharmacy? The honest answer is that at the moment, it looks like the Pfizer vaccine will have limited impact on our sector. The logistics read like something from a science fiction film, and there is simply no way that most pharmacies will be able to turn their retail areas into a vaccination clinic that sees 200 people per day, every day for 5 days, and also allows them to stay safely socially distanced. Instead, we must look to primary care networks. We must see how we can contribute to any local plans through them. We must do whatever we can to help, but crucially, we must be ready to jump in with a proposal the moment that we have a vaccine that looks easier to manage. Already, we have positive news about other COVID-19 vaccinations, which may be less complex to store and simpler to administer, and this could put the ball back in community pharmacies' court. We have evidence of the impact we can make from our fantastic flu season. At this point, we have already vaccinated more people in community pharmacy than ever before. That's 1.9 million people, a fantastic effort. And we must use that to make our case. COVID-19 testing too is an area in which I see a potential key role for community pharmacies in the future, particularly if the Prime Minister's vision for same-day testing to be available via test and trace in the new year comes to fruition. A pilot is already underway, and we must continue to position the sector to be able to do this, as our accessibility to the public is second to none. And what are our ambitions for the sector beyond the pandemic? The good news is that there are opportunities here too. I know many of you are struggling to access extra flu vaccinations right now, but I understand that supply from central government will soon start to flow more quickly. And who better to start to vaccinate the working population aged 50 to 64 than the pharmacies that this age group walks into as a matter of routine. My personal ambition is for the vast majority of this new cohort of patients to receive their vaccination, their flu vaccination, in a community pharmacy. That is, of course, an optimistic goal, but we are working to see to what extent we can make that happen. And that is not just an ambition about jabbing as many people as we can, although clearly I would urge all contractors to do that, but it is also about progressing our relationships with GPs, especially, and primary care networks, and trying to seek a truly collaborative approach to this and to all vaccination programs. Surely, one positive from the legacy of this pandemic must be that the days of competition within the health service are left behind us. We must play our part in trying to attain that vision. As a sector, we also have a lot to play for in the rollout of new contractual framework services as set out in the 5-year deal last summer. Yes, some of those have been delayed, but the pandemic has not halted progress entirely. It's my hope that by this time next year, we'll be starting to see the results of that ambitious service development program. We should by then have seen the success of the GP referrals to the community pharmacist consultation service, and I hope this will be a care pathway that's well walked by patients. Alongside that, we also want to see pharmacies paid for all the advice they give on a walk-in basis. The discharge medicine service will also roll out in 2021, and of course we want to see positive results from that. We may also get positive results from other contractual framework service pilots that we agreed with possible national commissioning of a wider range of clinical services. Finally, though, we must come back to money. We need to get you a resolution on those 2 outstanding funding bids. The delays in getting outcomes are maddening. We will continue to keep fighting for this. In every negotiation, we impress upon officials the immense pressures facing the pharmacies we represent, and we'll continue to give them all the evidence they need to back up our claims. It's only fair for you and your teams, the people who are not hesitating to put themselves in harm's way to keep serving local communities, that they are treated fairly. You must not be invisible or at best an afterthought to the powers that be, and we will work hard to progress this next year. So keep battling away. We are at Psnc on your behalf. We'll continue to do what we can to support you, and we will continue to stand our ground in negotiations and not accept offers that simply undervalue the critical work that pharmacies are doing. Thank you for listening. I look forward to hearing your questions. Now, back to Michael.
Thank you, Simon, for that frank, honest, and open presentation. Now it's your opportunity to hear from our panelists. We're ahead of time, which is great, very rare in these conferences. So we have lots of time to look at some of the debates that we're having and the questions that are already coming in that I've been having a look at during Simon's presentation, as well as listening to him, of course. Now it's your turn to hear from those panelists, 3 of whom are operating at the front line of independent contractors, but also very knowledgeable on the bigger picture. Firstly, Simon is going to join us again. Thank you, Simon, for staying with us. Then we have Aneet Kapoor. Aneet is an independent contractor from Manchester, chair of the largest LPC in the country, having overseen the merger of 6 local pharmaceutical committees. Reena Barai, an independent contractor from Surrey, member of the MPA board, Psnc committee member, pharmacy PCM lead, RPS London deputy chair, and a mother who has sacrificed the Great British Bake Off finals this evening that she was going to watch with her children in order to be with us. Now that's truly going above and beyond. And finally, we have Mike Hewitson, an independent contractor with 2 pharmacies in Dorset. Mike was an MPA board member for 8 years and is a local councillor and also a prominent pharmacy tweep, if you follow such things. So I am going to welcome all and thank you for participating in this panel session tonight. I know you'll add enormous value. Before I go to some of the questions that are coming in from the audience and those that were posted before we started this evening, can I ask each of you one question? What's one thing you think pharmacy owners should do right now? I'm going to start with Mike.
Thanks, Mike. Can you hear me?
I can.
Great. So I'm embarking on the same journey that I'm going to talk about. I think this is really important. The first thing I'd encourage all pharmacy contractors to do is upskill themselves. I think the absolutely critical enabler for so many services for the future is the ability to prescribe. Without that ability, it becomes difficult to alter treatment. It becomes difficult to do all manner of more complex interventions. We're seeing that pharmacists who are going to be graduating in the near future will be qualifying as prescribers at the point of registration. That's really exciting, I think, for the whole profession. And what I want to see is an army of community pharmacists who are out there able to fulfill their potential, delivering clinics in a community setting. In our area, there's a shortage of referral options for some conditions. Find out what your local gaps are, and then you can look to fill them. I think there's a really good future out there. I've never been more optimistic about the future of community pharmacy than I am now. That seems really odd in the face of what Simon's just said, but eventually the wheel will turn on the funding. I've no doubt about that. The NHS can't recruit enough GPs. There isn't enough money to throw towards GPs to make a difference anymore. So, we have to be there, ready and able when the powers that be decide that they want to try another option.
Some really good points you're making, Mike. I just want to apologise to everybody if we're getting a little bit of an echo on the line. I think it's because we have a loop in one of our speakers this evening, because we're keeping their mics on so that they can respond quickly. Rena, I'm going to come to you next and ask that same question. What one thing should pharmacy owners be doing right now?
Well, as usual, Mike stole my thunder, because that's one of the things I was going to say. But I think the thing that's probably keeping me awake, although not many things keep me awake because I'm so tired at the moment, but the thing that's kind of in my mind is creating that bricks and mortar independent pharmacy model that can't be replicated, that can't be reproduced, can't be displaced, can't be replaced. Specifically because of the Amazon news that we heard last week, and that's really been playing on my mind, thinking about, have I got the sort of pharmacy that people would choose to come to rather than go to Amazon? Why would my regular customers suddenly decide actually Amazon's a much better pharmacy than Rena's? And those are the sort of questions that I'm asking myself. I'm also, my poor staff are getting quite fed up with me, because I'm also kind of questioning my staff every time they interact with the patient, saying, did you do the best you could do there? Or could they have got what you just said from Amazon, the service you've just given, could they get from somewhere else? And really getting my staff to think about, do you know what, this is very real now, isn't it? That, this sort of large supply model could really take over. And if you think about how many times I get Amazon parcels just from my staff buying things online coming into my pharmacy, it's quite interesting. And if you look at the stats for how many people bought OTC medicines from the likes of Amazon and online purchases just in this pandemic, so that's a huge market we've already lost. I know, I normally stock up for cough and cold remedies over this winter period, and they're sitting on my shelf right now. Nobody's buying them yet. I know people are ill. And so they're obviously getting them somewhere else, and they're getting them online. So if I'm already losing that market, how much longer is it till I lose my prescription market? So I think people need to really think about that and think about how they can be better, how they can evolve, as Mike has just suggested, by becoming professionally, working at the top of their license and offering lots of services that are valuable, in a face-to-face setting that you won't get from an online provider. But also all of these things need to be sustainable. So the finances, as Simon has sort of alluded to, you need to have that business model that's sustainable financially, physically, with the extra costs of maintaining premises and things like that, and having staff, but also mentally. It's exhausting, isn't it, for contractors? It's very tiring to be constantly needing to evolve and constantly needing to change and constantly keeping up and worrying about money and all of the things we worry about. So lots of things going around my head, and lots of things that I think contractors need to be doing.
Thanks, Rena. That evolution and the pace of that evolution is exhausting, but it is the nature of life these days, isn't it? And if you look at any business, whether in health or any other thing, they're having to change. The hospitality industry is probably going through the biggest change it's ever done for a century, I would imagine. So yes, we're seeing that pace of change, and we'll come on to that as we go through the evening, I'm sure. Anit, both with your contractor hat on, but also with your LPC hat on, and you're seeing that across a broad breadth of people. What do you think is the one thing that hasn't already been referred to by Rena and Mike, and thunder being stolen? What one thing do you think you could bring to the fore?
Yeah, apologies. I was the echo. I tried to be clever by wearing a headset today to make sure I was clear, and then didn't realise that obviously the mic echoed straight back into the headphones. So apologies for that. So yes, well, didn't leave much left, did you, Rena and Mike? But I think one of the points that I wanted to raise, and I suppose it ties in, Mike, into what you've said there as a contractor and both as the LPC, and I'm probably in danger here of stealing Simon's thunder, but it's the persistent race to the bottom that we have within pharmacy, where we kind of lose sight of the value of ourselves as community pharmacists and as community pharmacies. And I think that's the bit that we need to refocus and realign our focus on what it is that we are and what services we actually provide and what value we want to place on that. You know, Simons has spoken publicly in the last few weeks around services that community pharmacy provide that bring little revenue back in, and we provide them free of charge. You know, deliveries being one of them, and that's, I'm sure, made conversations both locally and nationally very difficult in times such as now, where we want to stand up services for vulnerable patients. And you know, we sit in many meetings as the LPC where we discuss what community pharmacy can and can't do, and we're forever trying to get rid of the rod that we've created for our own back, where our stakeholders that we engage with see us with little value. It's because of what we have done, and it's our own behaviours that have precipitated this probably over the last 20 years or so, and like I say, in this persistent race to the bottom. And you know, we're talking quite frankly here, even if we talk about services that we have right now with the flu vaccination service, and you see the difference in the pricing when we have a private market and we have the NHS market, and if we're going to go out and in a private market and we're going to not put the same value on the service provision that we are providing to the NHS, then why would the NHS value us to the value that they have done now? And these are real dangers that we are creating for ourselves going forward, and probably tying, you know, Simon and his team's hands behind their back when they go into that negotiating table. And so we can have all the frustrations that we want as community pharmacies and as LPCs or whoever we are with national negotiations, but until we actually precipitate the behaviours and place values on ourselves at grassroots level, right down to branch level, we're not doing them any favours when they go to that table.
That's a really good point that you covered, Anit, and it's a nice segue for Simon, because you know, Simon, you asked for people to stop doing stuff for free, and an interesting story. It's not for me to be telling stories tonight, but I'll give you this one anyway. So I was in Zurich about a year ago with where my daughter was studying, and went into a local pharmacy. I had man flu inevitably, and went in to get some paracetamol, some ibuprofen, and it was like £6 a pack each for a pack of 16. And pharmacist served me very professionally, asked all the right questions, and wanted to know if she could help further, and was very professional. And I said, I just want to congratulate you actually, because you're charging a price that rewards the value of the service that you have just given me, not the product, the service. The product is an implicit part of that service. And we don't do that, do we? We don't value our time, we don't value our service, and as you quite highly highlight, Anit, whether it's giving it away free or just not valuing it ourselves. And if we don't value ourselves, how can anybody else, I guess? So Simon, over to you with that as a segue.
Well, Anit has successfully eaten my sandwiches, so not a lot I can say further on that. I did say it. I know also that it's easier said than done, and I do absolutely understand, and I see Rena nodding, you know, that when you've got your patients in front of you, to make that call and to say those things is really, really hard and not always possible. It was, I suppose, more the principle of the point which you might have made and Anita has made, and I won't repeat it. I think a couple of things I would say. You asked what's the one thing that businesses should look at. So if I can go back to that, and again, a bit of everything that everyone has said, I absolutely agree with. But it is getting on top of our finances as a business, and it is, I think, also looking for individuals, for people, and for other businesses and organisations to collaborate with as well. Whether that's primary care networks, whether it's other GPs, whether it's other community pharmacies, because I think looking forward and looking at the world that Mike Hewitson has described, I think that collaboration is going to be ever more important. So I would say that's the one thing, building those relationships, which I know many businesses have, but that's going to be hugely important for the future.
Yeah. Can I come back to you on that one, Simon? Because the PCN and that relationship with between community pharmacy, and we've got within the PQS, we've got a pharmacy PCN lead representing the pharmacies in its area. I was part of a webinar last night for some PCN leads that we're developing in Kent, and they were saying they're really struggling to engage their colleagues. Never mind the clinical director or the clinical pharmacist in the PCN. It's actually their colleagues that's part of the barrier. And if we can't do that, we can't show collaboration with ourselves, then how do we show collaboration with others? So do you have it's good to hear you reflecting on that, but do you have a view about the balance between local versus national? We've got the right review looking at some elements of what's the scope and remit of an LPC, and how much support should they be giving at local level compared to the work that you do collectively at national level, and the important work there that is underfunded at the moment, undoubtedly. What's your view around that balance without treading on too many toes, I guess?
No, I mean, I said publicly a while ago that local is the new national in many ways. There's more and more, that's clearly the direction of travel that the NHS has gone in and is going in. We see that through, especially at the pandemic, we've seen that highlighted as well. There will always be, and there must be, some national frameworks that need to be negotiated and contractual frameworks, but ultimately that is why the relationship, I believe, between Psnc and LPCs is so important, is because the closer that we can work together, the tighter that we can be as a unit, means that contractors on the ground get a better service from the national contractual framework straight through to those local services, and we need to make sure that the communication pipe is as clear as possible. So no, you can't put a percentage on what should be one and what should be the other, but there should be a more seamless. There is clearly a more seamless view of this from NHS, and we need to ensure that we too are more seamless in the way that we deal with it as community pharmacy.
So Anit, can I come back to you as an LPC chair this time, specifically around that local, which I know you've been stepping up in Manchester with the team and the academy and everything else that you've put together up there. Do you have a view around the amount of, or the importance of local support and training and the likes for contractors?
Yes, I do. And I suppose there's a national consultation and review process going on that kind of debates that on what that means, and I think I was quite honest when we were looking at that, when we talk about representation. For myself, representation equals support and support equals representation. I think it's very, very difficult to divorce the two, and I think when you're looking at support is obviously across the board, and we probably haven't evolved as representative structures over the years to ensure that the role that we fulfill when it comes to support is articulated very well, and it's probably in a kind of pick and mix across the country, where areas have evolved and other areas kind of stuck to the party line as such and not kicked on. So there definitely is that role, because the local relationships, if we look at what the NHS Director of Travel is that's where it is. And I think you were talking about the PQS. This is the first PQS when it comes to engagement that there is an onus on general practice to engage with us as well, and that's key. And I think what's happened in the past with the PCNs especially is the leads have been people who you've got a number of different types of contractors, some that are a bit au fait with what's going on nationally, some that are very much, you know, can't get their head above the parapet because they're just blinded by what's in front of them on their checking bench, and they're the ones that you're probably struggling to engage right now. Those that kind of can see the landscape probably engaged in the last round earlier in the year. Some of them became leads, which was really positive. I think if we can build on what we've seen with this PQS, although, you know, it's a bit of a challenge because of the pandemic, but where we've got general practice to have an onus to engage with us, then we will see more community pharmacies on the ground actually see the value in engaging with the PCN, because I think that's what they're struggling with, is to seeing that value. Apart from being on good terms with the local doctors, there. And we really need to build on that now, and where we start looking at delivery through PCN as well. And to achieve that without local structures is going to be unbelievably challenging, because we are to be able to do that nationally. We can have national templates and national agreements, but to actually achieve that delivery without the local structures is going to be a real challenge. So that's where I think, obviously, to be able to do that, you're going to need what we provide in terms of the workforce development in certain areas, because the needs are going to be different in different areas. So providing that workforce development, providing those opportunities, and providing those skills.
That's some really good points, Anit. Thank you for that. Rena, you're a PCN pharmacy lead. I'm not sure what your PCN's called, but wherever it is and what it is, how's that going?
I'm really enjoying the role, actually, and I think it could be a full-time role, to be honest. And I think since COVID, it's really hit the ground running, because my PCN, which is called Cheam South Sutton, I'll give them a plug, have been really proactive and have set up community response teams, clinician forums, all sorts of things. And I've been on the at the table at all of those virtual meetings from the very beginning. And they've been really keen to ensure all the stakeholders are. So you've got, district nurses, community nurses, care home leads, social services, voluntary sector, community pharmacy, everyone sort of playing their part, which is exactly what a primary care network should be. And in terms of pharmacy, it's been amazing. I'm constantly being asked, Rena, can you present on the new medicine service, because we're doing a session on structured medication reviews. I got an agenda item at every meeting, so on every agenda paper there's a section that says community pharmacy, and that's never happened locally before. So for me, that development of primary care networks and then the community pharmacy leads has been really, really positive. But what I am worried about, and what I do hear from my contractor colleagues, is that this isn't across the board, and there sort of is a bit of a postcode lottery again in the way that PCNs have either formed, or the way they're engaging with community pharmacy, or community pharmacy engaging with them. And that's again my big concern, because otherwise we're going to have a very similar situation to what happens with some LPCs across the country, and all those sort of organisations. If we haven't got that kind of standardisation and that control over, I guess, in a way, how can we make sure that everyone's going to get the best out of that collaboration that should be happening locally?
Yeah, that's very good, very well said, Rena. And Mike, you're a local councillor, so very engaged in your community, both as a healthcare professional and as a councillor. So any reflections through your lens on that one?
Yeah, so I'm also a PCN pharmacy lead for 2 PCNs, including the best named one in the country, which is the Jurassic Coast PCN. So literally I'm a dinosaur, as I'm frequently reminded.
That's me.
Well, you said it, Mike. So I think there is everything to play for. So I'm a district councillor, but at the county council and the unitary level. So that's the level that would include the health and wellbeing boards. I know that pharmacy is well respected in our area. I think people are waking up to the value of that network in a range of locations, and also just seeing those people that nobody else sees. I think, you know, Rena and Neat will back me up on that. You know, we've got people that will tell you they hate going to see the doctor, they won't even ring up to get an appointment, won't even set foot through the door, but yet they'll come in and they'll chew our ear off for half an hour about, you know, whatever alarming symptom has reared its head. So, you know, I think there is massively increased the profile of pharmacy throughout this pandemic. The question is where we take this next. And for me, it's about turning the good conversations that are happening at PCN level into actual cold hard cash, into services, etc. The trouble is that PCNs are not set up as commissioning bodies, so we're sort of frozen out, even though we've got the relationship there of the financial loop. So I'd like to see, as PCNs sort of embed themselves, there being some way of feeding back income back into the sector. We're just in the process of thinking about how we're going to launch the GP referral for CPCS. And that's just a massive opportunity. And I've been trying my best to badger them into going this side of Christmas, because the whole point of going this side of Christmas is it's there to help with winter pressures. And yet, because, you know, priorities within the team, it slipped down the agenda, and they want to do it after Christmas. And typical thinking, to be honest, they want to go low risks. They want to go out with a slow rollout, and I'm thinking, actually, you want to go out with a bit of a bang. You want to change behaviours, and you want to ensure this message is consistently heard across the patch. So yeah, I think there is still quite a big job to influence the way that people think, particularly in the sort of managed sector, because, you know, we're entrepreneurial by background. We've all taken risks to set our businesses up. We all take risk every day, and it's getting the other side of the conversation to start to take risks when perhaps they're not comfortable with that. So I think we have got lots of opportunities. We have got the start of good relationships. On the PCN role itself, it would be brilliant if it was actually properly remunerated. And sorry to beat Simon over the head with that one, but yeah, as Rena said, I feel like it could be a full-time role right now. I've got 2 PCNs, and I'm juggling my best in my working time to try and cover this commitment. But when clinical leadership throughout the rest of the NHS is funded, you know, you've got GPs being funded to be, you know, PCN clinical directors, etc. You know, I think we ought to be getting more than a token gesture. The PCN role this year has been a massive loss leader for me personally, and I know, as I can see Rena and Anit nodding there, you know, it will have been for every other PCN lead who is working their socks off to try and get things moving locally.
I mean, there's a specific question about that from one of our attendees tonight, which is doing all that great work that you're all doing at a local level to raise the profile of pharmacy. But how is that translated, or has it translated in any way into fee-paying services for the contractors you represent at that local level? Who'd like to go first on that one?
I think I don't mind coming in there, Michael, because there was something I just wanted to add on to what Mike was saying, and obviously that kind of role. And the reason why I was nodding profusely is because in our area as an LPC chair, we've got 58 PCNs, and trying to support that many, and Mike, you'll know very well on how that piece of work was at the beginning of the year when we were doing the upskilling, and unfortunately, you know, COVID hitting kind of restricted what we could do with them face to face, but we still needed to do that work. So they have kind of been dropped in a bit at the deep end, because we didn't really get that time with them earlier on in the year to be able for them to understand the NHS landscape and the dynamics of what it is to be like as a part of those meetings, and how to carry yourself, and what kind of things, you know, to engage in and what not to engage in. So it was very, very difficult. And, you know, I've got to commend the team back at the LPC, and we were talking before about LPC roles and the local support and what they've done for this PCN, because with everyone and the work that they've got in the day job at the moment, Mike is 100% correct that that PCN lead payment is nowhere near what the commitment is. And as an LPC, we've had to stump that up in terms of resource to be able to ensure that all our PCN leads are fully supported, having all their kind of admin and background work being done for them by the LPC team, so that all they need to then actually do is actually have the conversation. If they were then left to do that themselves on the kind of payments that they're getting for doing it, then there's no chance it'd get completed. It'd only take, really enthusiastic people like Mike that'd be able to fulfill it.
Yeah, Simon, have you got a view on that? Having heard what Rena and Mike have said.
In terms of the payment to PCN leads or the work?
Well, the payment, but also that return on investment. You're banging your head against the wall with nationally, and they seem to be struggling to get that conversion at local level as well.
But I mean, PCNs, are well, they've been in existence for a while now, clearly disrupted with COVID, and the potential that I think we were interested in seeing how they were going to develop has yet to perhaps to materialize. They are, so the NHS tell us, the future for those local services, and therefore we need to take them seriously. I think that you're right about the amount of time and effort that's involved in ensuring that there is good cooperation, collaboration, and linkage with different healthcare professionals at that primary care network level. The question is, well, if you want the pharmacy leads to be paid more, where is that money going to come from? And if that money is going to come from outside the contractual sum, we certainly have and will continue to make that case. But if it's to come from within the contract sum, question I suppose for contractors is, are they willing to pay for that from their pocket for that PCN lead? So there's some difficult negotiations there to be had.
Yeah, there must be a case in there for some of the money that's sitting within a PCN, and I've done some work with some to be allowed to purchase the time of a community pharmacy representative. That surely is a way forward, but certainly not from the global sum, I'm sure. So I want to switch over to a few other topics that are coming through on the question panel. Some of these are, let's go back to the financial bit that Simon, you articulated very well at the beginning, and these three contractors are feeling the pain of that at the sharp end. We've talked about things like distance selling pharmacy and the impact of that, and the risk of that. We talked about pricing of services and pricing of product, where we've had a race to the bottom, was the term that I think Neat used. If we were looking forward now, how do you think the financial landscape will look, Simon?
Looking when, Mike?
Well, over the next 3 years, maybe, because if you look at the Y report, that looks towards 3 to 5 years.
We've been very clear and put, as I said earlier, we've put forward 2 funding bids. I won't go through them again, and the COVID one is separate, I guess. But of course, what the Chancellor will say tomorrow is he'll give some high-level thoughts on money going to the NHS, and out of that, then we'll commence a process of divvying up that money into different pockets, and that we have put in a bid, as everyone knows, for an uplift to the contract sum for the remainder of this deal, because it clearly wasn't written with COVID in mind, and there are changes that have happened to the community pharmacy contractual framework, and what's required within it as a result. And we've seen not just some of the things that have been talked about by this panel, but also the quite marked change in patient behaviour that I believe is a permanent change, and one that needs to be reflected. And as part of that leads on to the, I think, very real issue of ensuring that community pharmacies are remunerated for all walk-ins to their pharmacy, all self-referred patients, not just the ones that are referred through general practice and through NHS 111. And you know, if you extrapolate that, that could make the whole process an awful lot easier to streamline the whole referral process by saying, well, you don't need then to have IT linkages between general practice and community pharmacy for referrals if actually you're going to get paid for people walking in and asking for clinical advice guidance from their pharmacist. So I think there are some important parts of that future that need to be funded appropriately, and ones that we've, as everyone knows, we've put bids in for. So I think from that perspective, that needs to be built in. The spending review that the Chancellor will talk about tomorrow, of course, is only for 1 year, and we've still got to then look at years 4 and 5 of the contractual framework. Costs are going up. Clearly there are huge pressures on community pharmacy. We've spoken about those before. We have been very clear to ministers and Secretary of State and others about those pressures as well, and we keep fighting to get them recognised and to get an uplift to the global sum.
So one of the themes that's coming through in the questions is around supply against services when we've got a contractual framework that is largely dominated by funding of supply, yet that's potentially declining because of changed behaviours and online opportunities that patients seem to be going towards in some cases. What about shifting that balance even further, more towards services? We've got that element in the contractual funding flows over the next 3 years, where the transition payments then transfer from an MBRs disappear, and then I think the MPA had a pink band on a graphic that they created, which showed that, but it's about filling that gap so that the contractual sum will, I know, Simon, come through. But what is going to fill that gap? Is it more of the services coming through on the pilots?
Well, we've got, don't forget, we've got if you're referring to the unallocated sum within the contractual framework, then yes, we've got of course, the GP referrals into the community pharmacist consultation service, the 111. We've got the discharge medicine service starting in January. If we had then agreement to have remuneration for self-referred patients, I think that would be a sizable chunk. We've also got all the other things that are in the contractual framework, don't forget, that we haven't even looked at yet. You know, whether it's the stop smoking referrals from hospitals, the hypertension case finding, all the antimicrobial stewardship stuff, you know, the changes to the NMS. You know, all these things are going to be coming online. All of these things will eat up that unallocated funding, and will be, you know, providing income through services.
I mean, one question, you could say slightly controversial, but stating roughly that many pharmacists aren't either ready, willing, or able to deliver services. They're fixed into a supply pathway, and of course during COVID that's what we've been focusing on. We've had to revert back to the safe supply to meet the needs, and service revenue has gone down dramatically, hasn't it? But how do we reset back to a service led, and how do we take the whole of the population of community pharmacy with us on that journey? Mike.
So I think all of us will probably agree that it's not a question of supply or services. The two go hand in hand. They always have and always will, as far as we're concerned, because the supply is what drives people through the door. It's what gives us that reason to interact and talk to somebody, and by seeing them you know, in my case, 12, 13 times a year at least, you get to build a relationship with people, and that becomes a therapeutic relationship on which to base services. So, you know, I'm not keen that you know, some people are quite keen on the divorcing supply entirely from services. I'm not keen on that at all. I think we have to find a way to make it easier to interact with community pharmacies. So from my point of view, you know, we've not mentioned technology at all this evening, and we have to embrace technology to make it easier to use a community pharmacy so that we can get the best of both worlds, really. So, you know, we're looking at putting in a 24/7 collection point now. I know lots of pharmacies are. In Wales, they've managed to secure funding to do that. And I think that is a really good way of showing that actually community pharmacy can evolve with the time. So while we'll have people collecting from the machine, we'll also be able to provide them services remotely. We're having a video conference this evening. There's no reason why we couldn't offer a consultation to a patient at a time that's convenient for them in their own home, with a product supplied from our machine the next day. You know, it's not rocket science. So I think we have to find a way to reduce the friction between the pharmacy and the patient. That then will help to minimize the risk of people going off to Amazon, because, you know, the best one in the world, you know, people might like the convenience of stuff dropping through the letterbox, but they absolutely hate it when stuff doesn't, and they've got to go to the post office or whatever, or rearrange collection. And it's a different kettle of fish if it's suddenly your insulin and you have to try and chase that round while some courier's chucking it in the back of his van. So, you know, I absolutely believe that supply is key to our future. Will there be a different mix of funding? Probably, and I'd like to see us embrace technology. So we're looking at Hub and Spoke as an example of how we might be able to make the system cheaper overall to run. But, you know, everyone's going to have to examine their own business models. There'll be areas where people can easily come together. There'll be areas where people can automate and already have done. But I think community pharmacy's great strength has always been its innovation, and that has primarily been driven by the independent sector. You know, we are the place where good things start. You know, 99 times out of 100. Our problem's always been about consistency and being able to scale those innovations across the whole network.
So there's a question just come in from somebody about Amazon Prime or Amazon Pharmacy against a vending machine, but I think you've answered that very well by saying it's not a lost opportunity to have an intervention where you could supply that. But of course, I suppose you could say any distance selling pharmacy could do the same using technology. From that point
But yeah, I think the thing that we've got there, Mike, that's different is we've got the relationships. So the thing in an independent community pharmacy is that you can have a named, accountable community pharmacist who will manage that relationship. Whereas, yeah, the best one in the world, you try and ring customer services at the largest internet pharmacy, and you'll get stuck in a queue for half an hour, and then they'll have to try and find your records, and they won't know you from Adam. So, yeah, I think there is a way of blending the best of face-to-face with technology to try and get the best of both worlds. Will it be for everyone? No, it won't be. But I think you have to try and offer as many different opportunities to engage with pharmacies as possible.
Thanks, Chris. And that's a great advert for one of the sessions we got on Thursday night, which is all about utilising technology to improve outcomes, both for the pharmacy and for the patient. So we have Sunil Kochar talking about using video technology for that. Anita and Reno, are either of you using that sort of technology?
Oh, I was just going to say, no, it's something I'm thinking of. So the video consultations, definitely. I've just been on a training course on how to run video consultations. And I was specifically thinking around some of the public health services we do that I feel are probably a real niche for pharmacy, because no one else is offering those services, and not many other sort of healthcare professionals take primary prevention as seriously as we can. And I really think the way we're placed in our communities, we've got our finger on the pulse, haven't we, of population health. we see well people, we see ill people, and you know, especially during these COVID times, we're seeing the ticking time bomb of mental health issues, weight issues, you know, financial issues, all of these things that have a real impact on people's you know, well-being and lifestyles. And for me, I think that's definitely a key avenue for community pharmacy to really kind of be working to push those services, not just the clinical, you know, focused services, but the primary prevention and public health. And I'd love to see more of those pilots that Simon sort of said that we're hoping to have happen in CPCF really start getting pushed through, because with the new Public Health England, we've got an opportunity as well to, you know, really think about ways that pharmacy can have that impact in the community.
Anit, anything on technology in your contractors?
So yeah, I mean, we managed to secure quite quickly early on in COVID was the remote consultations for some of the public health services. You know, EHC being one of them, namely, and there was a national kind of provider, probably international provider actually, that was allowing free access to their platform with the use of an NHS mail address, and which I ended up testing. And to be honest with you, I was quite surprised at how few pharmacies took up that opportunity. You know, and I actually saw the number of consultations that we were doing out of one of our branches actually skyrocket, because we were the only ones in the area that were still actually able to complete that consultation, which was great for us, because we were able to continue to have some service revenue. But it certainly outlines a model for the future that we can build on. So we had to do it kind of, you know, as a needs must, and it was kind of just testing the platform out to see how it worked. And you know, I agree with Rena there. Probably I might have should have gone on a course first before I did video consultations, because they can be a bit awkward when you're not too familiar with them. But once you've done the first couple, they're very natural, and they're quite easy to do. And I actually found a patient was more comfortable because they were in their own environment, they were in their own home, and they were much more at ease in speaking to you as well. And then they obviously appreciated the fact they could send anybody down to the pharmacy to come and collect what it is that they want. So that relates back to Mike's point, where actually if we develop this model, complete the consultation, they don't even have to come down to the pharmacy while it's open. If there's a 24/7 collection point, they can actually just come and collect that at their own convenience, or anybody can on their behalf. So definitely the technology needs to be developed, and the hub and spoke element, or efficiencies in dispensing generally, we have to be looking at those, because whilst we, you know, I totally agree with Mike around supply and services, and that kind of, you know, the marriage that they can't be without each other. We do need to look at where our dependence actually is as contractors. So when we look at our revenue and our income, we need to start focusing on the fact that the dependence is not on the actual supply function, and we need to start focusing more on the services. And when I say, I don't mean that in disregarding the supply. We need to find the efficiencies in the supply to then free up the capacity for us to be able to deliver the services. So where we actually, you know, look at our margins, and we are probably around 80 to 90% on supply for our margins, and only 10 to 12% on the actual services, we need to readdress that balance, and where we're actually putting more focus onto that in terms of our time and our resource, so then it's able to reward us back. Because the more these other models come in, DSP or whichever they are, the click and collect, that supply chain is going to get easier and easier for the patient, which is going to reduce the interaction. Now, unless we make our interactions with the patients ones of quality, then we're not going to see them again. And that's where community pharmacy is going to lose them. So we need to make sure that those interactions that we've got, they count and they're actually of quality. And that comes back to the point of what I made right at the start of value. And what value do we place on ourselves? Because if we can exhibit that value in what we, and it's not always monetary value, it's what we've trained to do. It's a value to the patient, it's a value to the community, and it's also obviously that will then naturally bring the income.
Yeah, it's what is it that they say, that the profit is the applause you receive for doing the right thing with the right people at the right time for the right people, but it has to have the fundamental framework that supports that, of course. So what I'm hearing is yes, wrap supply and service together, absolutely right. the two are interdependent and not independent. But we need to make sure that the funding flows along those lines as well, of course, and particularly if the aspiration of the government to reduce the cost of supply further, which was an aspiration in the 5-year plan. So let me just flip that on its head slightly and talk about private services and charging for services, which we started this conversation with to some extent, and the differentiation that might go with that. What is your view around building that private service and to some extent self-care, the OTC, the healthcare revenue that comes that we've largely lost or very much have lost because we've not necessarily embraced things like PMEDs as well as we might. What's your view around building that private service portfolio that augments and maybe reduces our dependency on NHS for our revenue? Rena.
I've got quite a few views on this actually. So for me, I've always wanted to just be an NHS provider, and I guess I've been a bit of a laggard when it comes to those private services, because I'm just so pro NHS, and I just wish all those private services were available on the NHS, because that's the whole point of the NHS, is meant to be free at the point of access. And I guess I felt uncomfortable charging patients for services. Having said that, this pandemic has really opened my eyes up to the fact that actually patients are willing to pay. Patients don't want to see their GPs. As Mike Hewitson said, we get so many people who are saying, Rena, please can you look in my ear? Please can you test my urine? I don't want to go to the doctor. Can you listen to my chest? Can you look in my throat? And these are all the things that I've been on loads of training courses to do. And it was a private service that I was, about to start in February this year when the pandemic hit. So I put it on hold at the moment, but it's one that I'm sort of reworking up to start again this December, because I guess I've changed my mind about it. The NHS money is not coming. I'm waiting for it. I desperately want to provide NHS services, but at the same time, I've got to be able to keep my premises, pay my staff, keep myself motivated, and utilize these skills that I'm gaining. I'm an independent prescriber. I've done all the the assessment courses I could do. I'm so highly qualified. I just can't use the stuff in my pharmacy and all the knowledge I've gained. And the only way I can do that now is to do it privately, which is a big frustration of mine. But I'm going to have to do it, and I believe there's a demand as well from patients.
That's a really interesting point. There's a couple of questions just come in on that around charging for services, either things that have been displaced from GP practice because people can't access it, so GPs referring to get your blood pressure taken or other monitoring parameters checked, but no fee for service. So can you charge for that? How do you feel about that? How do you feel about charging for MDS? How do you feel about the fact that you might think about charging for any other service? So Mike, your views on that?
So I suppose, like Rena, we've all been on a bit of a journey with this. So when I bought one of my businesses, the pharmacy used to charge for MDS and charge for delivery, and the first thing that we did at the time was to get rid of that, because that was just a done thing. And I suppose I have a reluctance to charge people for what I see as quite important in a rural community. No services. It really is a vital lifeline to a lot of people. So I'm reluctant to charge on that. But tell you what, I'm getting very, very annoyed with people ringing up for free advice who don't get their medicines from me, who may be using a dispensing practice or may use a different pharmacy, and they just want me to give them free advice. And I start by saying, well, can I take your name, please? Or I'll just look you up on my records. And then you go through that. Oh, I don't seem to have a record for you. Oh no, I don't get my medicines from you. I said, well, unfortunately, it wouldn't be safe for me to provide you with a service if I don't have a full history. So we started to get a bit cute with that. But on the question, I think private services are absolutely essential going forward. I can't rely on the NHS to fund the business. Our pharmacies have been there for 230 years this year. They were there well before the NHS ever existed. They'll be there hopefully for another 230 years. And they've done that by giving patients and customers what they want, from pulling teeth to selling cochineal beetles for dyeing hunting jackets, for goodness sake. one of my predecessors used to make all of the blood for the Hammer horror films, believe it or not. Seriously. I think pharmacy is brilliantly innovative. I've always loved this career. I think you'll see from the passion from Anit and Rena that we want to do all sorts of things. At the moment, the NHS is a barrier. It's holding us back, as far as I can see. One way to get around that is to create private services and then create a demand, and then maybe the NHS will follow. Maybe it won't, but I think unless we give customers what they want, people are paying for private GP appointments because they don't want to wait in a queue. Why aren't, I know what's wrong with them. There's no reason why I couldn't, supply the medicine for them, write a prescription for them. Maybe not at the same time, but I think pharmacies are brilliantly adaptive. Mike, you know that as well as I do.
Mm-hmm. Been there, done that. Simon, can I just come back to you? You asked in the summer, maybe June sometime, for people to stop doing stuff for free. How did that land, and what sort of response have you had to that from all the sectors, part of the sectors?
So Psnc is there to promote NHS services. The reason I took this job was partly because I'm a passionate believer in the NHS, and so it was a difficult thing to say, and I thought long and hard before saying it, that where the providers of these services, community pharmacy in this instance, are not being able to get reimbursed for, and you mentioned blood pressure checks, and there are a whole host of different services that pharmacies provide for nothing, then that just can't continue. It's not sustainable, and therefore we have to look at other ways of getting recompense for that. Now, I said it, yes, I stand by it, and interestingly, I would say that probably of the many emails that I received, probably about 60% were in favour of the people who were who took the trouble to email me. So I think that it's something that's getting traction and people understand. And I think perhaps Rena's point that what the pandemic has perhaps shown up is that perhaps a more willingness, not just to pay for services, but to realise what will get from community pharmacy more generally, actually, and that and I think that is part of that, overall reaction that we're getting from patients. And the survey that we took, the audit that we undertook over July was just incredible, with just looking at the self-referred patients into community pharmacy. 600,000 people every week self-referred, and when you extrapolate and look at the numbers, and when you ask those people what they would do if community pharmacy wasn't there, and the percentage that said, well, actually, 50% saying I would go to try and see my GP. Community pharmacy saving 60 to 70 GP appointments every week for every single practice in the country. I mean, it's just phenomenal and utterly undervalued by our customer.
So, there were a few questions around consistency, I suppose, consistency of experience, consistency of quality, but also consistency of collaboration. And one of our challenges, and the Right Review identified this, didn't it, Simon, that the sector is not as unified as it could be. I think it's more unified now during this pandemic, but it certainly is still not fully. And having one voice to government, having one voice to the public, a communication strategy is one of the recommendations that comes out of the Right Review, as well as a collective response and if you like, a pharmacy PLC response to everything that everybody then sticks to. What are your views, Simon, on that challenge?
Well, I've read all 133 pages of the Right Review, Michael.
Me too.
I can bore for Britain on it. It's a it's a really in-depth piece of work. There are I think some recommendations there that are easier clearly to enact than others, and the review steering group that's now been created will be looking at those. In terms of the narrative and what the sector can do, I felt right from the start, and it was interesting when I first arrived in this sector without baggage, clearly, because I came from outside healthcare, and I made the mistake of standing up and saying we need to speak with one voice, and someone said, no, you can't say that. You can't say one voice. But it's true, and I've said all along that provided we can speak with one voice, and there is much that brings the sector together, and the pandemic has typified that it makes it more impactful for us, for me and the Psnc committee and the negotiating team as negotiators. It's a more solid ability for us to negotiate with the other side, and it makes it more difficult for our customer and for NHS and our purchasers to divide us. And I think that's really important for a sector that's going through not only the challenges that we're facing at the minute, but also the benefits, the potential that community pharmacy has, as we've already discussed, for patients in the future.
Yeah, absolutely, and I'm totally with you on that, and the nods from the other three, very, very concurrent with that. I mean, we've got a number of questions saying, well, what about the multiples? They'll do this, or what about this organisation? They'll charge at cost price or less than I can charge. I can buy this at that, or somebody down the road will do deliveries if I want to charge for them, and those sorts of disparities. We've got to find a way of bringing that together, undoubtedly. I just want to flip to something else. We've probably got about 15 minutes left for questions. So I want to talk about the kind of e-commerce approach or the blended approach that maybe bricks and mortar, or as somebody calls it, clicks and mortar, might be thinking about. I can remember when I was at the MPA, Mike, we talked then about a click and collect approach for independence members, and the opportunities to do that. I mean, it's not hard to do. It's just about putting the time and the effort into creating that opportunity, whether it's through a single portal or your own portal. Anit, Rena, and Mike, either any of you got a sort of click and collect approach, or at least an e-commerce approach?
Sort of. So we've been ploughing quite a lot of money into trying to build a website purely for retail, and it's been hard going, really hard going. People think you just whack up a website, chuck some pictures on it, and then people spend money. They don't. You just have to keep plugging away. It's advertising and more advertising, and at the moment I'm toying with the idea of actually scrapping the whole thing because it's just not washing its face. So do we double down on that approach? If it's not quite working, do we sort of try and review why it's not working? We're using some really good people to consult and to help us, but it's not as easy as just whacking up a website and going, there you go. So I think it's about it's a horrible word, but omni-channel approach. So we've launched patient-facing apps, so you can do the two-way messaging with patients. You can collect the products in the pharmacy. We can deliver, etc. So we're trying to make it as easy and as frictionless to deal with the pharmacy as possible. But it's not a straightforward solution by any means.
Yeah, I mean, one person's just posted that they've just linked up with Amazon. I mean, Amazon take quite a big cut of anything you've got, but it's a channel that's there and you can do it. Rena or Anit, either of you done anything with e-commerce?
I haven't either, I think, but for that very reason, I just don't know which way to go with the website, to go with the app, to go with the collection boxes, to go with deliver everything out, and Royal Mail Postal Service. It's so hard, isn't it, to sort of figure out what do my patients want. I think they want a bit of everything, but I can't afford to invest in everything. And that's the problem that I have. Each of these things cost money, take money out of me, take my time, take some headspace, and you need somebody really on top of it, as well as everything else that we're doing in our pharmacy. And I think that's where every community pharmacy is struggling with this, because I see lots of great examples of one, great examples of another. But to bring it all together and to be able to really provide what every patient wants is possibly impossible. And so I kind of just think that's where I sort of started, didn't I, about kind of making sure we create that model that works for us, that's sustainable for us, that will tick the box for the majority of patients, and making sure that that service that we have and we choose to kind of deliver, be that with the box to collect outside, or be that via the two-way app, or whichever way, we do really well. I think it's hard to do lots of things and not do them well, and sort of please everybody. It's a really, really difficult task. And the main thing is the funding. I haven't got that spare cash to try experiment with these things, and that's really, really frustrating for me. I don't know what Anit thinks.
Interestingly, actually, e-commerce, I dabbled with it quite a few years ago, and actually spent a fortune on a custom built website. And like Mike says, I went as far as actually going the full hog, mate, and got burnt, because unless you've got, like Rena says, the time, the headspace, somebody that knows what they're doing to manage it, you've got it in your head, but how much are you going to do as an individual? And that's the challenge. There's only a certain number of things that you can actually manage yourself. So unless you've got the right people that are going to be able to run this for you, and they don't come cheap, and it's more upfront funding, because you're not going to see the fruits of that for quite some time with e-commerce. And the other bit is you're going to put in that funding, but for how much extra? How much are you actually going to gain by doing that? And is the cost of delivery actually going to be more than that? So there's a lot to think about it from the balance. I mean, so we scrapped it and we went back to a very basic website, but in the last 6 months with the pandemic, we've seen that there's an increasing demand again, but it's from our current patient cohort, that they want to access us remotely. So that's a very different model to then going full hog e-commerce, and it's about increasing your access. But the danger for me is, whilst increasing your accessibility and being remote, is we're not increasing patient expectation to create another rod for our back, where I emailed you last night and you checked the emails and it was at 10 p.m. and no one's got back to me. I needed my tablets. We need to be very, very careful that we don't create a rod for our back. We have our operating hours, and just because we're going to then have a web presence doesn't mean that we're going to have a 24/7 hotline that you can ring us because you weren't in when the driver came round and you need them now. And these are the real dangers that are always there for community pharmacy, and we kind of throw ourselves into something and go, yeah, let's do it, and it sounds great and everything, but then a few years down the line we go, okay, how do I get out of this mess now? And so it's about embracing it, but embracing it in the right way. There is just one point I just want to go back on, Mike. Sorry, and I know that you're chairing this really, really well, but we're talking about the private services, and I just want to add something around that. I mean, the private service element, I have no qualms in it at all, and I embrace it, and I have been doing for quite some time in delivering that, because it's around, if a patient is happy and that's what they want, and we're satisfying our patient, we're utilizing our skills. And it just comes back to my point before when I was talking about value. It's valuing yourself and what it is that you're able to offer. Now, NHS free at the point of access is what the terminology is. But if we look at it, honestly, we've got CPCS now, and we've got minor illness, and we're going to have GP CPCS. That is access to a pharmacist and an appointment. If that patient needs something to treat them afterwards, if you haven't got a minor ailment scheme, we're already embracing private services because we're selling them something. So for that patient, it's not free at the point of access. So our NHS services are already now moving us to where the patient has to take some onus and responsibility for their own health. So the NHS is kind of in one sense, showing what its boundaries are to what it will provide to the public free of charge. So if you've got patients that actually want to come outside of that loop completely and go, why am I even bothering with the GP to get to my pharmacist? My pharmacist is actually, if I go through that way, I'm limited to what I can get. A lot of it's OTC products at the moment, but if I can go to my pharmacist and get a UTI treatment, or I can get, like Rena says, get my ears looked into, or someone can look down my throat and do a strep test and prescribe my antibiotics, then we need to value ourselves enough to be able to provide those services, because if community pharmacy doesn't, we're already seeing other providers move into that space, and then that'll be another avenue that we'll lose.
No, you're absolutely right. And there are minor ailment services in many areas of deprivation, and there was a question earlier on that I didn't get to, which was about the perception, and it is a perception, it's a reality in some cases, but a perception in many that in some areas people won't pay. But Rena, you established that might have been what you were thinking, but actually it's not. And it's surprising in times of need. It's not about abusing professionalism, but in times of need, people make choices about what they spend their money on, and it's only appropriate. There was one point that Graham Phillips just made around not confusing e-commerce and online pharmacy. We're not necessarily talking here about the provision of NHS meds or even private meds. We're talking about non-medicine or non-prescription medicine business, which you could then create using online. I actually ran a website in my own pharmacies back in 1995, and we were doing very well nicely out of that at the time, thank you. But times have moved on. Competition certainly moved on since then. So I just want to go. Yeah, go on, Mike.
You mentioned Graham then, and I think this is a really good example of what we're talking about. So Graham's probably going to go bright purple now, as I'm going to say something nice about him. So Graham, you can kick me afterwards. So Graham has been developing a service where he's been helping people, pro longevity service, and he's done some brilliant work in helping to coach patients through the whole lifestyle change. He's been using continuous blood glucose monitoring to help re-educate patients. And this is the point where I'm going to die of embarrassment, but Graham's actually been helping me for the last 2 months, and I've lost nearly 2 stone now in helping Graham through Graham's help. And that's doing things like these video consultations. Graham's been a fantastic support. We pay for that service, and people value the service that they pay for. I think it's been a brilliant experience for me personally, and I wouldn't hesitate to recommend it to patients, because people do value what they pay for, and if you can show somebody a tangible output, people will pay to go to Weight Watchers, they'll pay to go on all sorts of weird and wonderful diets and stuff, but actually just being able to talk to somebody and just help you through a difficult time, whatever, that can be a real benefit.
Absolutely. I've seen some great examples from that service around reversing early onset diabetes, type 2 diabetes, and Graham's just blushed, if you can blush in a message on a message just coming through just now. So can I take you back to some points that you started with? Rena, you mentioned the D word, the differentiate word. I think it was you right at the very beginning, and what differentiates a community pharmacy, a bricks and mortar pharmacy from an online, even if you then become a blended product. What differentiates you from another pharmacy in your area? And I think we've all clearly articulated that the differentiation is the quality of the experience that the patient values, not necessarily the cost price, but the value price. So the wrapper that you put around it, whether it's going beyond, going to extremes, supporting people in consultations and the likes. And it seems to me, and perhaps if you can just do it by a nod of the heads, because we're running out of time, that people do value that if they get the good experience, and they can access it at the right time, and they'll pay for it. Yes. So let's take that one through. The other thing I want to talk about very briefly, Mike, you're going to be training as an IP. Rena, I think you're already on way to be. I don't know whether you are one already. Yes, that's right.
I'm an IP.
You're an IP. So, you know, we didn't pick you because you're IPs. We picked you because you understand the market and you can articulate what you do and why you do it. So that upskilling to an IP, some people have said, well, it's been squashed. It's not an opportunity for independent pharmacy, but we've got 3 people here working in independent pharmacy who are all becoming IPs off your own bat, I imagine, not with any supported funding. But and there was talk, Simon, correct me if I'm wrong, when Keith Ridge spoke to the LPC Psnc conference in the summer, or through a video link, I think, or something like that. Didn't he mention building IP into making it accessible for community pharmacists?
He did, yes. Well, we were all in a video link, obviously, yes, he did, and he talked about community pharmacy and the pathway to IP training, and we're yet to find out more about that, and we look forward to doing so. But I underline what everyone else has said about it. You know, when you look at the direction of travel, as we talked about earlier, community pharmacy, it's the natural progression, not just because of the clinical aspect and the services and the linkage to dispensing and everything that's been talked about, but also about what patients want from community pharmacy, and it is the natural progression, whether that's part of an NHS funded service or whether it's part of a private one.
Yeah. So you believe that will be a direction of travel either within or outside of the NHS?
Yes.
Thank you. And the other thing I just wanted to go back to is how pharmacy is seen by others. And again, going back to the Wright report, Simon, that was one conclusion that we needed to have a communication strategy. I think it wasn't clear in the report, to me anyway, that was about communicating to the public, to say to the public, this is community pharmacy, this is what it can do for you, go there, they can help you, whether that's private or not, I guess. So Simon, your views on that?
I think, well, a communication strategy, it all depends on, you know, and many years ago I was director of communications myself, and it's about the audience, right? And it seems to me that while of course we want to maintain the offer of community pharmacy, so the patients and the public know about it, but what's become very clear, as we've said many times over the last few months, is that they do know about it. And what the surveys that the NPA and others have done, shown how valued community pharmacy is by patients. So what I would say is the communication strategy actually should be wider than that, and our strategy should be encompassing other healthcare professions, as well as, of course, our politicians, who again, I believe, because their constituents tell them that value community pharmacy. And I believe ministers and Secretary of State do as well. But then that strategy is also, the communication strategy needs to get through to officials, it needs to get through to other government departments, it needs to get through to policymakers and opinion formers. And that is the communication strategy, the joined up communication strategy that I think we probably need, and I think that David Wright was probably alluding to.
Yeah, absolutely. You know, there are, some people would say there are 2 brands in pharmacy. One is a very large corporate brand with a blue oval, and the other one is pharmacy as a brand. And that's often people like Anita, Rena, and Mike at the coalface, and the people they see and the relationship they have with them. We're going to have to call it a close now. I just want to say a massive thank you to all. Sorry to anybody who didn't get their question or the theme of their question asked this evening. There is a bit of a theme coming through on pre-reg and some concerns about funding and accessibility of placing for pre-reg, but I think that's for another agenda to be discussed. I don't ignore it. It's a very valid agenda. there's a belief, I believe, out there in the populace of our contractors that extending the role of practice, whether it's through IP or as well as through IP, but through prevention agenda and protection agenda, is very key. And the other theme that's coming through loud and clear is how can we differentiate each other, ourselves from and make that consumer patient experience something that we are about. Now, Thursday night, we're going to have some opportunities to do that, and I'll come on to that in a minute, I hope. But I just want to say a massive thank you to Simon, Anit, Rena, and Mike for giving up their evening for the sake of everybody else. And before we move on, just my mortal thanks for what you do day in, day out, guys. I've been back in practice again after 43 years of being in practice. I'm back in again and loving every minute when I do. So it's hard, yes, but it's very, very rewarding, isn't it? But thank you to all. And I'm going to close off the panel discussion then. And Simon, we'll see you again on Thursday night. And I will see you guys, I am sure, in another space. Thank you very much, all of you. So, some reflections on there, which I kind of summarized at the end there. Some really good questions. So thank you for everybody who posted questions during this Q&A panel. I hope you found it informative and inspiring to some extent. In this dynamic landscape in which we're operating, there are an awful lot of unknowns still, and many things are out of our control. What we do need to know is that a service-led model, as indicated by the panelists, is going to be the future, but with a supply function embedded in it, whether it's part of the CPCS, whether it's part of dispensing and the new medicine service and everything that goes around that, the discharge medicine service, whether it's OTC sales and the quality of the customer experience and the consultation around getting that particular consultation right. It all is about a service-led model with a product embedded in it. The product might be a service itself, whether that's quit smoking or whatever. We also know that dispensing alone is not going to be a sustainable future for pharmacy. The margins reducing, patient nominations for EPS are increasing, and therefore those who have online capability will see faster growth. Consumers want a different and a better experience. COVID has accelerated the move towards more online and digital solutions, and you heard that from Mike in particular then, as well as Anit and Rena. Reintroducing services is both urgent and important. We've done a massive job, as Simon said at the beginning, around flu vaccination, 1.9 million. That's 200,000 more than the whole of last year, and we're only just getting into the next phase of it with the 50 to 64-year-olds, which is a big opportunity, as Simon indicated. The new medicine service, and hopefully we'll start to see that expand, but the fact that it's now integrated as part and a requirement to integrate as part of the structured medication reviews in primary care is really important. And this is what the NHS wants to buy from pharmacy, and it's what it needs, what patients need. And it builds our relationship with patients as a clinical provider, but it also builds our relationship with other providers. Pharmacists must build that self-care business that we've mentioned a couple of times today. We need to leverage the PMED. We need to make sure that we develop a suite of private services that are relevant to the local market in order to become less dependent on the NHS for profitable revenue, sustainable revenue. But coronavirus is probably here for now and maybe for some time, even with the vaccine coming down the line. So we must plan for delivery, assuming those pandemic conditions. So that kind of tailors what we do and how we might go about that. But change will require leadership, strong leadership, and it will require leaders and managers to be determined, resilient, and tenacious. I'd now like to launch our second poll of the evening. Once again, similar question, it'll pop up on screen. It's asking the same basic question, but I want you to think about how you feel now, having heard what you did from the panelists about the future of your pharmacy. How confident are you now? I'll give you 30 seconds to fill this one out. Okay, can we draw that one to a close then, please, and publish the results? So the bottom two figures, the non and slight confidence have definitely gone down. Moderate confidence has gone up marginally. High confidence is roughly about the same. So there's definitely a shift upwards in confidence. And I'm hoping that when we ask this question again on Thursday night, when we'll be talking about how you do these things, not just why and what needs to be done, then we'll have a greater opportunity to boost that confidence even more. And I hope you join us for that. We close that poll now and then return to the slides, please. So I just want to say, let no one in the government and the NHS be in any doubt. Pharmacy cares for the patients we serve and the communities that they live in. Now, the government and the NHS need to care for pharmacy. I would also say that pharmacy needs to care for itself and create its own future. Once again, I'd like to thank our sponsors, AAH, Bristol Laboratories, Glenmark and Sigma. Just an indication of what's, oops, sorry, we've flicked on too far. That's my fault. Just an indication of what we're going to be talking about on Thursday evening, when I do hope you'll join us. We'll have Sanjay Gambier talking to us about how he's operationalized the flu vaccine service, but you could apply that to any service during the pandemic. How we utilize technology with Sunil Kochhar talking about how we're going to do that. Identifying efficiencies. We bring in a gentleman who you may be familiar with called Andy Chilton from Varesco, who has supported many pharmacies to improve the efficiencies and identify latent time that we can leverage and use for other services, and just creating that time and space, the biggest gift you can have to start thinking about a plan. And then we have Deborah Evans talking about how, if you've created that time, what do you then do with it? And how do you create a plan that will take your business forward for the future? And then we'll have a short pharmacy leaders panel to look forward. And that will bring back Simon to the evening, together with Mark Leonette, Ashley Cowan from AAH, and Julian Mount from Alliance Healthcare. In case you missed it, I just want to, in the promo video at the beginning, just to remind you that the Pharmacy Business Award has shifted this year to the 21st of January. It'll be a virtual event. And we do have Matt Hancock lined up for that. And we hope he will make it through the winter and be there on the night. I'm sure he will. And I know he would have liked to have been here tonight if he could. If you can't make it in January, I hear there's an ex-president with nothing better to do than have a spray tan and play golf. So maybe we'll bring him in. So finally, it falls to me to say a big thank you to our speakers, our panelists, and to you for attending most of all. We look forward to seeing you again on Thursday evening. Please tell your pharmacy friends and colleagues to join us. And that just leaves me to say good night, stay safe, thank you.